Hello, I'm Liz Tremaine and I'm an occupational therapist working in the Stroke and Neurological Rehabilitation Service. Today I'm going to be discussing the role of occupational therapy in cognition and perception following stroke. The objectives of this session are to look at developing an understanding of the cognitive and perceptual changes following a stroke, the role of occupational therapist in assessing and treating those cognitive and perceptual problems, and also starting to develop an understanding of strategies you may wish to use in your clinical practice to help support stroke survivors with cognitive and perceptual difficulties. So what is cognition? I'll give you a few moments to consider what it means to you and within your clinical practice. So cognition is very much considered an umbrella term because it covers a variety of skills. And so in this slide you can see there are two definitions. The first is that it covers all mental processes involved in communicating, remembering, knowing, learning, understanding and awareness. And the second just really puts it in a bit more detail. Our ability to learn and remember, to organise, plan, problem solve and attend, our ability to understand and use language and how we perceive the environment. So you can see a broad range of skills that we use every moment of every day. So considering cognition, up to 2/3 of stroke survivors will experience a cognitive deficit after a stroke, and this may range from mild to severe. Approximately 1/3 of those will go on to develop a dementia. Around 16 to 20% of stroke survivors with a cognitive impairment will improve, and more than that will develop strategies that help enhance their function. Most of the improvement occurs in the first 3 to 6 months after their stroke, but for stroke survivors this progress may continue for at least a year and for some of them up to 2 years before their progress starts to plateau. Now, cognitive impairment can be considered an invisible disability because it's less visible to the naked eye and less obvious, for example, than someone with a severe weakness. And therefore, it's really important that we carefully assess cognitive impairment, that we understand what difficulties the stroke survivor is experiencing, and that we support the family, the carers, and the multidisciplinary members in understanding what the problems are and the strategies that we can use to manage it. Now, severe cognitive impairment can be a significant barrier to rehabilitation because stroke survivors may not be able to attend or retain the information within rehabilitation, which affects their engagement. And often or not, severe cognitive problems can be more disabling than physical problems with a poorer prognosis. So when we look at the recommendations for cognition, we're very much guided by the Royal College of Physicians' National Clinical Guidelines for Stroke, which were published in 2016, the 5th edition. And what they recommended is that we should have routine screening for stroke survivors to make sure that we are very confident in assessing their level of cognitive function using standardised measures. That we also make sure that a stroke survivor who is not progressing as expected in rehabilitation should receive a detailed assessment to determine whether or not it's cognitive impairments that are responsible for that progress not occurring. And for stroke survivors with acute cognitive problems after a stroke, where they're being transferred from a hospital to another environment, for example home, that we carefully assess any risk factors to support their successful discharge or transition to another area. And carrying on for those recommendations, any stroke survivor that's returning to cognitively demanding activities, for example work and driving, should have their cognition fully assessed. And those that are continuing to experience cognitive difficulties should be considered for comprehensive intervention guided by the occupational therapist in order that they start to develop those compensatory behaviours and adaptive skills to help their recovery and to regain their level of independence where possible. Now, there are many different types of assessments we can use to help identify cognitive problems. Initially, we do an awful lot of information gathering, including self-reports from the stroke survivor about the problems they feel they're experiencing, but also their family members, their carers, and all members of the multidisciplinary team, because this allows us to get a full perspective of how our stroke survivors are functioning and difficulties that we might be noticing. We also observe them within their daily activities, again looking at their presentation over a 24-hour period. And then from there, we look at doing more formal assessments. So the occupational therapist will be involved in doing a neurological screen, looking at their cognition. And this may include their understanding on recognising objects, how to use objects, their orientation to time, place and person, their ability to recall their past as well as current effects, and also their ability to remember information both immediately and after time delay. We will also be looking at their insight. Are they aware about the effects of their stroke, how it affects their function, and also what support they currently need. In addition to this, we'll be doing a range of functional assessments to look at what the stroke survivors' cognitive skills are when they are moving, getting on and off furniture, when they're doing their eating and drinking, their personal care, and for things like how they're managing snack preparation and hot drink preparation. After this, we will do a range of standardised assessments, and these are formal assessments where we're very much stuck to a script and we assess that person according to their normal population. Our basic standardised assessment following a stroke would be the Oxford Cognitive Scale for those that have sufficient language abilities. But those that do have more significant cognitive issues, we may be doing a non-verbal test, for example, the butt test of non-verbal reasoning. And where we identify some problems in those baseline standardised assessments, we will then assess their cognition further using more detailed assessments that may look at their attention. For example, the test of everyday attention. We may be looking at their memory, for example, the Rivmead memory test. Or we may be looking at their executive skills, for example, the behavioural assessment of dysexecutive syndrome. The hierarchy of cognitive performance components is a really useful tool to look at different elements of our thinking and how those elements of thinking link together. Now, there will be certain foundation areas of thinking that will help inform higher thinking, as shown in this hierarchy. For example, if our stroke survivor has a problem with sustained and focused attention, at that lower level, it may then affect the higher abilities. For example, they may not be able to perceive objects in their environment because they haven't attended to the visual information coming in, or they may not have heard and registered new information, again, which will affect their memory and their recall. And it's really important that we assess all layers within this hierarchy, because what we don't want to do is misdiagnose issues with object recognition and memory where the problem might well be attention. So attention is the foundation skill within that hierarchy of cognitive abilities that we saw on the previous slide. And attention is the ability to receive information for processing. Now, there are 5 levels of attention. Focus is the ability to focus your attention even for a very short period. Selective attention is the ability to focus on that information and really to ignore any distracting information. Sustained attention is our ability to maintain attention on that task. And those are our foundation levels of attention. Our higher attention includes alternating and divided attention. Alternating is where we switch our attention between 2 tasks or 2 pieces of information. And divided is where we attend to 2 activities at once, or more than 2 activities, known as multitasking. Now, our stroke survivor may have difficulties in one or a number of these different levels of attention, and they may show the following issues. They might be quite distractible, leading to problems initiating sequencing activities or leaving activities incomplete. They may have difficulties retaining information because they're not attending to the information to be able to store it. They may be slow to respond, and they will often be unable to multitask, so activities will need to be done in a sequential order, one after the other. Where stroke survivors do try and multitask, you might find their performance deteriorates. For example, if they're walking and talking, the quality of their walking may deteriorate, or they may stop walking to be able to hold a proper conversation. The Stroop test is quite an interesting test that looks at your selective attention and your mental flexibility to inhibit your responses. So on this slide, what I'd like you to do is just to read the word and not the colour. And I'll give you a few moments to do this. And on this slide, what I'd like you to do is to read the colour of the word and not the word. You will see that this is more difficult because you have to use your selective attention to focus on the colour and not the word. And also you need to inhibit your response so that you're not saying the word. And again, good illustration of selective attention. There are a number of educational strategies that may be helpful for a stroke survivor. Fundamentally, it's really important that we provide the stroke survivor with education so they understand what their attentional difficulties are, how it impacts their daily activities, and what strategies might be helpful. In addition to this, we also need to support the education of the family member and the carer and the multidisciplinary team, because we need to provide a consistent 24-hour approach to how we manage attentional difficulties. It's really important that we help to reduce distractors in the environment so that the stroke survivor can focus either on the task or information coming in. It's really important to have an organised environment, so you can see on the two pictures on the slide, making sure the environment is visually very organised so it makes it easier for them to attend and process incoming information. And that we start off with a quiet environment so they're not distracted by noise. And then as the stroke survivor improves, we can then increase visual and auditory distractors for them. It may be that we need to prompt our stroke survivor to focus their attention, and this might be a verbal prompt, a gestural prompt, or even a physical prompt, just to allow them to focus on that piece of information. And that might help them initiate and sequence an activity, or to be able to register incoming information to help them remember it for later on. It's important initially we look to do one activity at a time, and again, as the intention improves, we might be looking at the stroke survivor alternating or dividing their attention, doing more than one activity. And critically, part of our strategies will be to provide clear feedback to our stroke survivor to know how they're progressing and any changes that we may need to introduce. So perception, what is it? Perception refers to the ways in which incoming sensory information is organised and interpreted in order that we can make sense and understand our external world. Now, perception is very much looking at interpreting information that we see from environment and using our thinking skills to make sense of it. So in this picture, look at what you can see. Can you see a vase, or can you see two faces, nose to nose? And it really does illustrate when information comes in, it's only by our top-down thinking and our past experience and learning that we make sense of it. And similarly, within this picture, what can you see? You can either see a face, or you can see a person in a heavy coat looking out into the dark. And again, information coming in and your thinking skills making sense of that information. Now, there are a number of basic visual perceptual skills, and this can include colour, our ability for our stroke survivors to be able to recognise colour, various shades of colour, and be able to differentiate one colour from another. And for some of our stroke survivors, that can be a real problem. These basic perceptual skills also include depth and distance, our ability to determine what distance one object is from another, and also the distance from ourselves. And again, you can see that within the picture of the railway line. As the railway line moves away, it gets smaller, so it gives us a concept of distance. For our stroke survivors though, they may have real difficulties in identifying depth and distance, and this can be a real problem when it comes to moving around their environment, managing steps, when they are reaching for objects, and for example, even when they're pouring, if they're unable to understand these concepts. We also have figure and ground perception, and that's our ability to identify an object from its background. And again, for some of our stroke survivors, that can be very difficult. They're not able to differentiate an object from its background. So therefore, we may very much need to think about simplifying their visual environment so that have very few objects and only the objects in relation to the task. It might be that we need to use colour contrast to make sure that the object sticks out from the background. And we might need to use block colour rather than any pattern colour just to help with that. And it might be we need to guide and talk them through what objects are in their environment and where they are in relation to their supporting surface. There is form constancy, which is our ability to recognise objects at different orientations. And for some of our stroke survivors, they may find this very difficult. They might be able to identify a piece of cutlery or a cup in an obvious environment and in an obvious orientation. But again, if that object is moved, they may find difficulties recognising it. And there's a little bit of an illustration of this on the slide with the guitar. Are you able to recognise the guitar when you're looking down on it as opposed to when you're seeing it straight on? There is size constancy, which is our ability to understand that objects can be at different sizes when they're at different distances from us, but they are still the same object. And again, for some of our stroke survivors, this can be a problem. So for example, if you're looking down a street, understanding that the house at the bottom of that street is not a smaller house, it is just further away. Position in space is our ability to understand space, understand what is the concept of in and out, up and down, inside and outside. And again, for some of our stroke survivors, that can be very difficult. They may lose that concept, so being able to reach for objects in their environment, being able to dress, can be very problematic for them. And lastly, there is topographical orientation. The ability to orientate yourself around the environment through specific destinations. And for stroke survivors that have difficulties with topographical orientation, this may cause difficulties being able to orientate and learn new routes around a ward environment, but they may also have difficulties orientating themselves around familiar environments like their home environment, where they are in their community environment or in a work environment. And that's something we need to carefully consider. There are a number of basic perceptual treatment strategies that may be helpful, and you will be guided by your occupational therapist involved with a stroke survivor. Again, importantly, education is key, making sure the stroke survivor, family carers, and multidisciplinary team understand what the problem is, how it's affecting their daily activities, and actually what strategies we need to be using as a consistent approach. It can be really helpful to grade the number of objects within a stroke survivor's environment, starting off with just the key objects they require, and as they start to improve, increasing the number of objects. It's really important to reduce the level of overlapping items, because if there is lots of items on a surface, whether it be a table, a bed, in the bathroom or in the kitchen, that can make it really difficult in terms of identifying objects, a sense of space, and the foreground and the background. Using colour contrast can be really helpful in actually simplifying the visual environment for the stroke survivor. And as you can see on this presentation here, even with the choice of 2 food dishes, the first one has very little colour contrast. It makes it more difficult for the stroke survivor to understand depth, distance, figure and ground, and to be able to clearly identify what food substances and cutlery are being used. Whereas alternatively, in the centre photo, there's a lot more colour contrast. It's easier to see. And actually, colour contrast within the environment can be very helpful. It can help differentiate steps and help with distance. It can help identify a rail from the background wall. So really important things to consider, both within a home environment and also a clinical environment. It's useful to place objects in obvious orientations and in their obvious environment to start with. For example, making sure that cutlery is very clearly seen from where the stroke survivor is positioned, and also making sure it is within either the dining room or the kitchen environment. You must also sort of support the stroke survivor in using verbal instructions or guide their movements when they're reaching for items, and try and explain what their visual environment's like, their sense of depth, distance, foreground and background, and have a conversation on what they understand from what they see, chat them through it, and then you can guide them. So body scheme is another of our perceptual skills, and it involves an understanding of our body parts and position in space. And this is very much learnt through our experience of movement and activities. So body scheme includes our ability to name our body parts and understand their functional purpose. For example, hands are very much used in our environment for reaching and manipulation of objects, and also they're used for gestural communication. Body scheme is involved with understanding about changes in positioning that we're required to do when we're doing all of our activities. For example, getting on and off furniture, walking and doing our personal care. Now, there can be a variety of deficits within body scheme after a stroke. The first one is asomatognosia, and that is where we have reduced awareness of our body scheme. And often for stroke survivors, they may lose awareness of their affected arm and leg, and they may not associate that arm and leg with their body scheme. This can cause distress if they see that limb, but also they may be unable to use their arm or their leg within function. They may also have a condition known as anosognosia, where they have a reduced understanding of how their stroke has affected them. This can be quite difficult for stroke survivors. So for example, if they've got a severe left upper limb or lower limb weakness, they may not be able to understand or have insight into that. And that really can affect their function. For example, those stroke survivors that may be attempting to mobilise and be at high risk of falls. There may be difficulties with left and right discrimination, where stroke survivors are unable to determine left and right, and this really can affect activities like dressing, be able to find the right sleeve to put your right arm within it. They may also have difficulties with finger agnosia, so that's their ability to understand what their fingers are and what purpose their fingers have, and their thumb. This can really affect stroke survivors' ability to grip and do gross grip, their ability to do pinch grip when they're picking items up, but it also may affect their ability to do things like tripod grip, which they would use when they're writing. And again, for stroke survivors, this can really cause problems with their hand dexterity and affect their ability to do their daily activities. There are a number of strategies that may be helpful with body scheme. Again, education of patient, family members, carers and the multidisciplinary team are vital. It's good to encourage the stroke survivor to use their arms and legs within their daily activities, supporting them, whether that be verbally through gestural cues or through physical support. When you are supporting them, name their body parts. For example, I would like you to use your left hand to wash your chest and under your right arm. And again, that's helping you name the body parts and discriminate left and right, but also to help reinforce what the functional purpose of their body parts are. Encourage normal movement of the arms and legs when you are assisting the stroke survivor, and also encourage them to name their body parts and also to name left and right, just to help reinforce their body scheme. There may be a number of recognition problems stroke survivors may experience. Firstly, there's visual object agnosia, where the stroke survivor may find it very difficult to recognise objects within their environment even when their vision is sufficient. And this can cause real difficulties being able to select the correct object for the task. And you might notice for stroke survivors, they select an incorrect object, for example, a comb to brush their teeth. Or it might be they're using a spoon to cut their meat. And again, it's really important that we identify and support them where they're experiencing this difficulty, and also that we assess for risks. There can also be a condition known as prosopagnosia, which is also known as face blindness. So the stroke survivor may find it very difficult to recognise familiar faces, and that can be faces of family members, close friends, and even themselves. And again, that can be very distressing, both for the stroke survivor and the family and friends that are involved. There can also be auditory agnosia, where the stroke survivor finds it very difficult to recognise sounds, and that can be sounds like fire alarms, it could be the telephone, music, and even speech. And again, that can have a significant impact on the abilities of the stroke survivor, but also in some situations it can cause some safety risks that we need to be aware of, particularly if they are changing environments and being supported in more of a home environment. So when we look at what recognition strategies would be helpful, education is key. It might be helpful to label items and place objects in familiar, obvious orientations and the most obvious environment to start with. It's important to maybe reduce the number of objects in the environment to make it more easy to recognise the objects, and encourage the stroke survivor to explore items in their hand, because they will start to then feel the tactile qualities as well to help them differentiate one object from another, as well as looking at it visually. With face recognition, it's important to try and encourage stroke survivors to pick out the familiar features of familiar family and friends, but also to be able to try and discriminate those difficulties and differences. And it might be important where there are severe problems with facial recognition that actually close members of their family and their loved ones do have a label just to help them with recognition. It may be useful to practice listening to different noises, so for example alarms, telephone and music, so they can start to try and identify those noises and differentiate it from others. And really important is to consider the safety implications for our stroke survivors, as well as particularly in facial recognition problems, psychologically supporting them, because it can cause distress if they're not recognising themselves or their immediate family, as well as supporting the family. Visuospatial attention is our ability to attend to our visual environment and to all areas of the environment. Some of our stroke survivors may have difficulty attending to part or half of their environment, termed as neglect or inattention. And there are a number of types of inattention or neglect. Egocentric is where a stroke survivor may have difficulty attending to the left or the right half of their environment, depending on which way their body is orientated. And the neglect can happen in different areas. So a stroke survivor might experience a difficulty attending to the left or the right side of their body. This may cause difficulties when they're doing their personal care. They may only comb the left side of their hair, or only dress and dry the right side of their body. It can also occur in their peripersonal space, which is within arm reach. And again, this may affect their abilities to identify and find objects on the left-hand side if they're doing meal preparation or making a hot drink. They may have difficulties locating their cup to take a drink if it's on their left-hand side, or they may only eat one half of their meal because they're not seeing the other half of the plate. You can also have neglect or inattention in your extra personal space, so that is beyond your arm reach in the far distance. And for stroke survivors, this may cause problems when they are walking. They may knock and bump into doorways, or they may be unable to navigate around obstacles in their environment. And again, it's really important that we assess for egocentric neglect and look at what problems it might occur within their daily activities. So allocentric neglect is a slightly different type of neglect. It doesn't rely on what the stroke survivor's orientation to the environment or the activity is. So within this, stroke survivors will see all areas of their environment, but they will only see one side of each object. So for example, in the picture you can see on the slide of the boy and the girl, in allocentric neglect, they would only see the right-hand side of the girl and the right-hand side of the boy. Whereas within egocentric neglect, which was on the previous slide, they would only see the boy and not the girl. So again, it can be really interesting to assess and have a little look at if they can only see half of each object, how does it affect their ability to recognise that object and use it within their daily activities. So there can be a number of strategies that are helpful for neglect or inattention. Again, education is key. We need to get the stroke survivor to understand that they have difficulties, and with inattention, stroke survivors are often very much unaware. So it's a process of educating them, family carers and the multidisciplinary team, and actually assessing and managing the risks that they might encounter. So good strategies to use are to encourage the attention for the stroke survivor to attend to their affected side, to attend to their arm and leg, and to rotate their body round, crossing their middle. Help them to use their affected arm and leg and encourage their visual attention to that side. Encouraging to move their head and eyes across and making sure that they are scanning their environment, and where they're not scanning the environment, that you prompt them to do so. It might be that you start to move objects in their environment towards the side that they're less attentive to, so they start to increase their attention and orientation to that side. And that can be done by using colour markers. You might mark out a part of their table, the side of their plate, just to help them attend to the side that they're struggling to attend to. It might be that you need to verbally prompt and also guide movements to the side that they're less attentive to within their daily activities. And when they are doing activities, encourage them to talk through what they can see. Get them to look over their shoulder on the affected side and look up and down in their visual environment, chatting through what they can see. And every time they move their body position or they change their orientation, again, get them to look over their shoulder and chat through what they can see. And if you notice that they're not looking and seeing objects in their environment when they're mobilising or when they're doing activities, chat them through and encourage their head and eye movements into that area. So going back to that cognitive hierarchy, the next level is memory. And what is memory? It's our ability to remember facts, past events and experiences, and it is very much an active process, looking on building on our past experiences and existing knowledge of information and facts with the new incoming information. And memory is an essential part of our daily lives in order for us to be able to function. So there are a number of processes involved in memory, and any one of these processes or a number of them may be affected for the stroke survivor. So encoding is our ability to register incoming information and make sense of it. And we know that the deeper information is processed, the more personal it is to us, or the more emotional connection, the easier for us to register the information, link it to what we already know. We then have storage, our ability to store that information, and we tend to store information with similar information. For example, like a filing cabinet, similar information is stored with each other in an organised way. Now, for some of our stroke survivors, they might find that they have difficulty storing new information, or that their information is stored in a very disorganised way, which makes it very difficult to access later on. And there's also the process of retrieval. Retrieval's the process of accessing the information from your memory when you need to use it. And again, for some of our stroke survivors, they may have difficulty retrieving the information or retrieving the information in a timely way when they need to use it. There are also a number of different types of memory, and again it's really important that we assess and look at what our stroke survivors' abilities are and any problems within these. Sensory memory is our very temporary memory that's used for a couple of seconds just to register incoming information, whether that is visual, auditory information or information from our senses, for example, movement. We then determine in this level of memory whether or not it's something we need to attend to or whether we discard it. And then information from that sensory memory moves on to our short-term memory. And our short-term memory or working memory is that memory while we are dealing with that information that tends to be seconds up to a couple of minutes and stores between 7 to 9 pieces of information. If information is processed effectively, it will then transfer to our long-term memory, which can be a few minutes to actually our earliest memories of childhood. And within long-term memory, there are different types of memory which are stored in slightly different areas. So therefore, some of our stroke survivors can have certain aspects of their long-term memory affected while others are spared. And for other stroke survivors, you may find problems in a number of their long-term memories. So semantic memory is our knowledge for general facts and general information. Our episodic memory is our knowledge of episodes of our lives and memories of our day-to-day activities. Procedural memory is our memory of how to do activities and the sequences that are involved, for example, walking, driving. And our perspective memory is that memory for remembering things for the future, remembering appointments, remembering to post something when you're going next to town, that type of memory. And again, for stroke survivors, if they have problems within their short-term working memory or their long-term memory, that really can impact their day-to-day activities. So there can be a number of strategies that can be very helpful to support stroke survivors with memory difficulties. And again, you will be guided by the occupational therapist involved with the stroke survivors' care. Education is key, which I mentioned with every area that may be affected. And in activities, you might need to provide prompting for a stroke survivor to start or sequence an activity. And that might be a verbal prompt, a visual prompt, or a physical prompt. When we're providing information, try to avoid information overload. Break information down into manageable amounts for the stroke survivor and check their recall. So when you're giving them information, ask them to repeat it back. And if they're having difficulty, repeat that information for them and actually break it down into further parts. It's important to provide orientating information, where they are, what time it is, what's happening, what previous learning you might have been doing within therapy, and also to practice the orientating information that you're providing. So give it to them, practice their recall, and it might be that you go back a little bit later on and say, do you remember the information we were discussing or the activities we were doing? Because it helps them to practice that new information. And it helps them with their storage and their retrieval. If they're finding it difficult to remember information that is seen or difficult to remember activities they've done, provide information written down in a place that they can see it. And it might be useful to support them with the use of a diary so that they keep a record of the activities they've been doing, but also a use of the diary to help them with that memory for the future, the perspective memory we discussed on a previous slide. It might be helpful to support them with the use of a notepad that they can write down important information that's given to them. And also the notepad can be helpful to organise activities they need to do, for example, to-do lists. Clocks, particularly calendar clocks, can also be very helpful with orientating them to time and place. So it's also very beneficial to help stroke survivors with developing a new routine or getting back to familiar routines, so there is structure to their time. Apraxia is around motor planning. And motor planning is our ability to formulate a motor plan and to execute it. And that can be from all activities, so getting washed and dressed, drinking, driving a car. There can be deficits in motor planning after a stroke. For example, idiomotor apraxia, where the stroke survivor may understand the concept of the activity but have difficulty executing that plan. There may also be ideational apraxia, where actually the stroke survivor has real difficulty understanding the concept of the activity. And this can include understanding the sequence of motor movements that needed to be conducted to achieve the activity, for example, eating and drinking. They may also have reduced knowledge of the properties of objects required to do the task. For example, they may choose a ruler rather than hammer to hammer in a nail. They may also not understand the mechanics of the objects they're using, so that a hammer is hard and heavy and that will hit the nail into the wood, whereas the ruler has more flexibility and bends. So there are two different types of apraxias, and again you'll be guided by the occupational therapist about what type of apraxia the stroke survivor has, or if there is a combination of both apraxias. And they'll also discuss what strategies may be helpful. So there can be a number of errors that we can identify in stroke survivors with idiomotor and ideational apraxia. With idiomotor apraxia, where they have difficulty executing their movement plan, but they understand the concept of the activity, they may show reduced spatial awareness and orientation when they're moving their body, particularly their arms and their hands. So you may notice that they have difficulty reaching to the right level, or that the orientation in the hand is not required for the task. They might have difficulty initiating movement, and what you might find is the movements might be very hesitant, absent, or they'll start a movement but they won't complete it. You will also notice that there might be issues with timings in movement. When they're starting to move, the various different parts of the body don't move at the right time. So for example, on a reach and a grasp, you would use normal movement like this, whereas you might find they are doing the movements, but the timing of the different body parts is not correct. Movements might happen with a different level of force than is required for the task. So they might put too much force or speed in doing a reach, or when they're gripping, they might grip too hard or too softly, which can cause problems. Some of our stroke survivors may use their body part as an object. So if you ask them to comb their hair, they will use their fingers to comb their hair. And equally, if you ask them to clean their teeth, they may use their finger. Often or not, they will use increased gestures, and they may get stuck on a particular part of the activity and persevere. So it's called perseveration, and it might be, for example, when eating, you might notice they persevere just with trying to load food onto the spoon. You might find their movements become quite fragmented, and that means they stop, they start. They might also have reduced coordination. So many stroke survivors don't have that selective fine movement and could look quite incoordinated, or as they describe it, quite clumsy. They know what they want to do, they can't execute the right movement, and often or not, they have insight into it. And we often find with idiomotor dyspraxia, having the object in hand and a familiar object to them helps them perform that motor movement because it is almost done in a subconscious way. Ideational apraxia, where they have reduced idea of the concept of the movements they need to do the activity, have some slightly different errors that you may notice. They will often have difficulty selecting objects, so they might use an inappropriate object for the task. Like I said before, a comb to do their teeth. They may have reduced sequencing, so they can't maybe initiate or sequence step by step of the task, and that ordering of the task becomes quite muddled. The actions, they might start an action and it might be left incomplete. And they might do two actions together. For example, if you were spooning coffee into the cup, they might do the spooning and the stirring all in one movement. And again, like ideomotor apraxia, they might get stuck with a specific element of that task. So there can be a number of strategies that will be helpful for apraxia. As I mentioned earlier, education is key, and you will be guided by your occupational therapist, and it's important for apraxia to make sure we have a consistent 24-hour multidisciplinary approach to it. It's important to provide education to help insight, particularly where there is ideational apraxia, where often stroke survivors aren't aware. It's important to provide verbal, gestural and physical prompts to start an activity, but also to do each sequence of the activity. Support the stroke survivor to select the right object for the task, and encourage them to explore items in the hand so they start to understand the properties of that object and the mechanical advantages of using one object over another. For example, hot drink using a ceramic cup over a paper cup. Support the stroke survivor to use the objects in activities, and you might do it initially by demonstrating how to use a toothbrush, how to use a comb. And if that's difficult, it might be you need to use support to guide their movement so they're doing the correct movement with the object. And for some stroke survivors, pictures of the different stages of doing their activity can be helpful. Break the activity down into little components and support them with each component of the task. And that will allow the support with the sequencing. And for our stroke survivors, it's really important that when we're practicing the sequencing of doing activities, we practice them doing that without any errors, using an errorless learning approach. Because if the stroke survivor repeatedly makes errors, that becomes part of the new pattern for doing that activity, which we want to try and avoid. Executive skills are a higher level cognitive skills which we use every day for activities like getting up, washed and dressed, managing childcare, driving, going to work. So when we look at what these executive skills are, it's being able to develop realistic goal setting, both on a day-to-day basis, but also looking at future goals, looking at how we plan and organise not just ourselves, but members of our family, within a work environment, within a home environment, and also a community environment. How we self-initiate activities and how we maintain our self-direction when we're doing activities, comparing it to our plan and seeing whether we are keeping to the plan we've done or whether or not we need to change our behaviour. It's also our ability to self-inhibit, our ability to monitor our performance, correct our performance and adjust our behaviours according to the environment with which we're operating. Our ability to sequence activities and do one step after another, to problem solve our difficulties, to process information at a processing speed that allows us to manage our activities effectively and efficiently. How we time keep, and often not how we multitask all of the demands placed on us within our daily lives. So stroke survivors may have a variety of difficulties within their executive skills following a stroke, known as dysexecutive syndrome. And they may present with a number of behaviours or difficulties. They may experience impulsivity, where they may rush to do activities or rush in their response, and they may take risks because they don't take time to process the information or consider their abilities. And this can lead to participation in high-risk activities. They may have difficulty sequencing tasks. They may be quite passive in their approach to activities, so they don't tend to initiate. Or when they're doing activities or when they're communicating and thinking, it may be quite disorganised. They might get quite distracted, depending on the level of multitasking or the type of environment they're in. And they may get very stuck in an activity or thought. They may find that they have difficulty turn taking And if they have difficulties with insight and memory, they may provide justifications or try and fill in gaps which don't necessarily reflect their true performance or the true situation. They may have reduced awareness of the consequences of actions or behaviours. And they may have difficulty understanding things that are a bit more abstract in nature and more complex activities like finances. They may also be disinhibited, so they don't have that ability to filter their impulses. And they may also have poor insight into their support needs, their risks and their abilities, which can incur some safety issues. So again, there are a number of skills and strategies that can be helpful when stroke survivors are experiencing issues with their executive function. Education is critical for the patient, the team and the family. General strategies that might be helpful for you to use in your clinical practice when you're doing activities is to ask the stroke survivor what they need to do before they start an activity, rather than having instruction. Ask them how they plan to do the activity and what support they feel they need. That helps them with the planning, the organisation and with the insight on what their abilities are, what challenges they might experience and what the support they need. Ask them to consider what difficulties they think they might encounter and also what activity order they're going to do that activity in. It's helpful to support the stroke survivor to organise their physical space because it helps with their planning, their organising and also their sequencing. And if they're doing quite a complex activity or even a familiar activity that they're having difficulty with, try and simplify it and reduce the number of stages so we make sure that it's successful for them to complete. You might need to provide cues to help them start an activity and carry on an activity. And also you might need to give them cues to reduce any behaviour that's not helpful to them. Prompt the stroke survivor to monitor what they're doing so that they monitor and they evaluate how that compares to their plan, and help them to identify any problems they might be experiencing. And if they identify a problem or you help them identify a problem, prompt them to look at how they're going to generate those solutions themselves rather than give them the solution. You can then explore with them how effective that solution may be and support them into selecting the right solution for the problem they're experiencing. And that can all be done around grading their level of risk. And again, take advice from the occupational therapist and the multidisciplinary team on that. So general tips which can be used throughout a range of rehabilitation is making sure we understand the stroke survivors' needs, aims and hopes, and that's really pivotal in any activity or session that we're engaged with. Support their emotional strength because it's a very challenging time. We need to make sure that psychological support throughout their rehabilitation is continued. Support their motivation and self-efficacy, and support where they are achieving and actually grade the activities that they're doing to ensure that they've got a sense of success. Help them understand the problems they're experiencing, and it's really important to provide information and education that allows for consistency among patient, carers, multidisciplinary team, and create opportunity for them to practice. Make sure we've got the environment set up so that they can achieve. We don't want the environment set up so that actually they're not having good success from the activities they're doing, because that will lower their motivation, it will lower their mood. And it's really important to give time. In order for a patient to practice strategies, they need to have time and opportunity to do that. Occupational therapists, physiotherapists, speech and language therapists and the whole multidisciplinary team can provide appropriate guidance and teaching techniques that is bespoke to the stroke survivor that you're involved with. And keep things as clear, calm and simple as you can. And actually, if in doubt, start things extremely basic. It's easier to make things more complicated as stroke survivor improves. And by that way, you're allowing things to be in its most simplest form, for then there's greater chance of success. So I thought I'd include this slide on cueing, and it's just looking at how we support stroke survivors through verbal, visual, tactile and physical cues. It's really important not to give too many instructions, because then all the cognitive skills we want the stroke survivor to practice is coming through the member of staff, family or carer. So it's really important to try and use open cues where possible. Do you want to start? What's next? And that allows the stroke survivor to start to cognitively engage with the activity. It starts to get them thinking about the planning, the organising, the initiation. For some stroke survivors, that isn't sufficient, so we might need to grade a structured cue. For example, you've washed your face, what's the next step? Or what do you need to dress? And as you can see, that's given them a bit more information, but still they're having to think about the next steps. If that's more difficult, a multiple choice cue. Do you want socks? Do you want shoes? And it doesn't necessarily need to be verbal, it could be a visual cue or a gestural cue, but giving them a couple of options. And then if they're struggling with a multiple choice cue, it's then that you would give them the direct instruction. Put the toothpaste on your toothbrush as an example. So it's important to try and grade that and not just start with direct instructions first, because that's really helpful for their cognitive rehabilitation. Now, there are a couple of activities which in a classroom session we would be doing face-to-face, which you might find valuable to have a little look at what you've learnt within this presentation and how you might apply it within a clinical scenario with a stroke survivor. So activity 1 is where you're working with a stroke survivor who has difficulty focusing her attention, difficulty remembering new information and planning activities. And within her personal care, she gets very distracted, has difficulty initiating and doing step by step, or remembering which step she's completed. What I'd like you to do is either singularly or within groups, look at how you would set up that activity within personal care and what strategies would you use to support the stroke survivor. And activity 2 is similar. You're working with a young stroke survivor who's very impulsive, has low risk awareness and difficulty monitoring his behaviour and problem solving his difficulties. So thinking about eating and drinking, he often rushes, knocks items over on the table, and he finds it difficult to select the cutlery and judge the space to reach his plate. He gets stuck in repeatedly loading his spoon and holds it upside down. He does overload the spoon as well, and he doesn't clear his mouth before the next mouthful. Again, within eating and drinking, which you'll routinely be supporting stroke survivors with, how would you set up the activity? And from the strategies we discussed in this session, what do you think might be helpful to trial? That's the end of the presentation. What I'd like you to do is think about what you're going to take away from the presentation, what 3 main things, and what you might like to improve on. And if you've got any difficulties, do please chat to the person facilitating the session, or you can email, and I'm on liz.tremaine, TREMAYNE -ward @nhs.net, and I'll endeavour to answer your queries. Thank you.